Well, good morning, everybody. I'm Catherine Sowden, and I just wanted to give you a brief update and overview of abnormal bleeding and where we're at with it in the DHBs, and hopefully that you will get some information to take home that you can use in your everyday practice. So my take-home messages today are early intervention investigation gives the best possible outcomes with regards to abnormal bleeding. And hormonal suppression and hormonal use is your friend, and don't be afraid of intervening and giving these women the hormones that they require. And endometrial hyperplasia and cancer is a preventable disease and is an increasing incidence, and it's something that we all need to be aware of in our practices. So abnormal bleeding is a very large problem, and it carries a very large social cost. As you know, many of your patients will take many days off work and school and takes time out of their social interaction to deal with this problem. So we divide abnormal bleeding into two categories, premenopausal and postmenopausal. So premenopausal was defined in heavy and irregular bleeding. That heavy is a little bit more subjective, but an average menstrual cycle has bleeding for 7 days with a cycle length between 24 and 38 days with a loss of 30 to 40 mils. Now this of course is a little bit subjective, but irregular is more objective, and this includes intermenstrual bleeding and irregular cycles. Now it's important to note that initially when menstruation starts, the anovulatory cycles are due to the immaturity of the hypothalamic pituitary axis and are normal. So it's really important when dealing with abnormal bleeding is to ascertain the cause. FIGO has come up with a relatively straightforward classification system, and this is for non-pregnant women of a reproductive age. So we have PALM and COIN. PALM is looking at structural causes such as polyps, adenomyosis, gliomas or fibroids, and malignancy and hyperplasia. COIN are the non-structural causes, so coagulopathy, ovulatory dysfunction, endometrial causes, even things such as, for example, an atrophic endometrium, iatrogenic, and we know that certain interventions can cause abnormal bleeding. For example, the Jadel is associated with quite a high rate of abnormal bleeding in young women, and there's another not yet classified for everything else that doesn't fit into the other categories to fall into. But it's really important when you see these women that you try and actually ascertain what's causing the problem so you can best manage it. So premenopausally, and you'll know this from health pathways, the investigations, history and exam is imperative, and full blood count, ferritin. We must do a pregnancy test, thyroid function, and then sometimes hormones and coagulation is indicated. Smear and swabs. And then the big question, I think, for primary care is when do you have an ultrasound and when do you need to do a Paykel? So when to do an ultrasound, and it's a little bit confusing because there's different pathways for different DHBs, which doesn't really make sense because a woman with certain risk factors that lives on one side of the road in Otahu and the other really is at the same risk. However, we are doing some work to try and standardise these pathways to make it easier for GPs. But in the meantime, so when do you need an ultrasound? Any structural abnormality, for example, if you examine them and they've got an adnexal mass, BMI over 30, if you're in the county's catchment, if you're over 30 years old, more than 3 months of failed treatment, more than 3 months of intermenstrual bleeding, and a haemoglobin of less than 90, or endometrial cells on a cervical smear in a woman over 40 years of age. So once you've got your ultrasound and you get the endometrial thickness, again there's variation between the different catchments what you need to do. So an endometrial thickness on a premenopausal woman on a scan of less than 12 millimetres, if you're in Auckland or Waitemata, you don't need to do a Paykel, but in counties we encourage Paykels. And to continue on medical management or consider a marina, we need to know that the Paykel is normal. Or if it's insufficient, we do make the assumption that there can be no significant pathology. An endometrial thickness of 12 to 15 millimetres is the same across all the different catchments. Paykel must be adequate and normal for you to continue medical management and through to marina. And if there's ongoing problems, then of course you need to refer. And then an endometrial thickness of more than 15 millimetres, a Paykel is essential, and it also requires a formal assessment in the form of a hysteroscopy, so referral is important. But the Paykel is also very important because it's a way of triaging these women, and we all know that the waiting times are enormous, the DHBs, and if we have a Paykel when the woman is referred, it's very easy then to triage them accordingly in a safe manner. And in fact, in the county's catchment, before COVID, we started to reject women that didn't have a Paykel, and then during COVID, because we knew that it was so difficult for women to get to GPs and difficult for GPs, we kind of flagged that and saw people as routine. But now that things are returning to normal, we're going to start rejecting referrals for premenopausal women without a Paykel. So it's really important within your practice that you have someone that's comfortable doing that with an interest in women's health. So other referral criteria are fairly straightforward, like if there's a structural abnormality, of course, or no response to medical management. Postmenopausal is quite simple. Any bleeding more than 12 months post last menstrual period is defined as postmenopausal bleeding. Again, history and examination is very important. The pathway says if there's not a smear within 3 months, then a repeat smear needs to be taken, plus or minus swabs, and of course a transvaginal ultrasound. And there's differing recommendations depending on the catchment for postmenopausal bleeding as well. So 1 episode of bleeding and a normal ultrasound, that's an endometrial thickness of less than 5 millimetres. Please try Ovestin, there's no need to refer. The chance of being endometrial pathology is very, very small, less than 2%. However, if it's more than 1 episode or the endometrial thickness is more than 5 millimetres, then we would encourage everyone to do a Paykel. And then if it's in counties catchment, then they need to be referred, and all women with a 5 millimetre endometrium or more will have a hysteroscopy. But if you're in Auckland or Waitemata, a normal Paykel between 5 and 8 is sufficient. So in trying to standardise these guidelines, we're looking at starting to look at our data at counties to make sure we're not over-investigating. I don't think we are, and I'm going to come on to that later, but I think it is important that we try and standardise this management as much as possible because it is a little bit confusing within the region. Just a little bit, postcoital bleeding, polyps, abnormal cervices. Important with postcoital bleeding, 1 episode normal exam, you don't need to refer, but if recurrent postcoital bleeding or polyps more than 2 centimetres or any concerns with the appearance of the cervix despite the smear, then please refer. So I'm just going to take a minute to remind people how to take a Paykel. We do take, we encourage GPs to come to our clinics at counties to participate in Paykel taking, so you can either upskill or just remind yourselves. And we have clinics every week that we're able to facilitate GPs coming and taking part in. So just a reminder, the woman is supine on your bed. Most GPs unfortunately don't have lithotomy stirrups, which makes it a little bit more difficult, but you can put the woman in the frog leg position. I think it's essential if you're going to be doing Paykels to invest in a tenaculum because that stabilises the cervix. It also decreases the angle between the endocervix and the uterus and makes it much easier to pass the Paykel. Just place the Paykel gently up till you feel the resistance at the fundus, and then you can pull down the plunger, and then you just go in and out a few times and twist the Paykel around and aim to fill up the plunger, the little tube, with endometrial tissue. And sometimes you need to put the Paykel in and out 2 or 3 times to do this, but it is important that when you take it out and you put it into your formalin pot that you keep it sterile and you don't touch the pot, don't put it in the formalin and then put it back in, and then it's quite safe to do 2 or 3 passes. And we find most women tolerate it very well, but we do warn them it might be a little bit crampy. So what are we looking for when we do a Paykel? We're looking for significant endometrial histology, and we're looking for malignant and pre-malignant change so we can manage it. And as I said in my introduction, endometrial cancer and precancer is a preventable disease. So we're looking for, obviously, for cancer hyperplasia, but there's some other more subtle changes that have crept into pathology over the last few years. Moral metaplasia, papillary proliferation, disordered proliferation, and necrosis, and proliferative endometrium in a postmenopausal patient is not a normal finding, even though it is in a premenopausal woman. Postmenopausal woman should have an inactive endometrium. So premenopausal abnormal bleeding management options. So medical management you're all familiar with. I'm just going to quickly go through this. Iron, tranexamic acid, non-steroidals, Panadol, and then the surgical managements, hysteroscopy, polypectomy, myomectomy, ablations, open myomectomy for large fibroids, and of course hysterectomy and uterine artery embolization are all the management options that we have for these women. And postmenopausal, again, we can use, with some of the precancerous changes, we can use hormonal options. And also if they have if the bleeding is because of atrophic causes, Ovestin is important. And of course the same usual surgical interventions of hysteroscopy, myomectomy and hysterectomy. So what are the new things that we're dealing with endometrial pathology? Well, one of the things that I think you're probably all aware of is the incidence of endometrial cancer in New Zealand and globally is increasing. And we're seeing this come through an increase in the amount of women presenting with abnormal bleeding, because endometrial cancer is a spectrum that starts from you have a normal endometrium and then changes occur over the years and eventually it turns into hyperplasia and cancer. And why is this happening? Well, we know it's related to obesity, and the obesity epidemic is not going away. And so this is going to continue to be a problem in all of our practice. So we know the normal BMI, your relative risk of having an endometrial cancer is 1. Whereas if you have a BMI of 40 plus, which is classified as class 3 obesity, the relative risk is 7.1. So there is a massive increase, and I think it's our responsibility as practitioners to address this with these women and encourage them to adapt healthy lifestyle changes. So the New Zealand Health Survey 2020 to 2021, 1 in 3 adults in New Zealand is obese, 34.3% women over 15, of adults over 15, and that's up from 31% in 2019, 2020. And the significant increase, interestingly, is women and not men. And the prevalence of obesity amongst adults, as you're probably aware, differs amongst ethnicity, with 71.3% of Pacific women and 50.8% of Maori women, as opposed to 31.9% of European and 18.5% of Asian adults obese. And of course, we know that adults living in the most socioeconomically deprived areas were 1.6 times as likely to be obese as adults living in the least deprived areas. So how does obesity cause endometrial cancer? We know that obesity causes complex endocrine and metabolic changes, but predominantly it's because of the increased circulating estrogen, and eventually over time that stimulates the growth of the endometrium. In a premenopausal woman, it can suppress ovulation, therefore it suppresses the natural progesterone release, and eventually mutations occur in an overstimulated endometrium. And this eventually results in hyperplasia and cancer. So early endometrial abnormalities such as disordered development can manifest as abnormal bleeding. So it's really important that abnormal bleeding is taken seriously and that we have a low threshold to sample endometriums. And the early changes are very reversible with progesterone. There's also a lot of management of later endometrial changes and early endometrial cancers with progesterone as well, some of which has been quite successful. There was a study called the FEM trial that was looked at over 150 women between 2012 and 2019, and we participated in this at Middlemore. And obese women with a BMI over 35 were allocated to 3 groups. Treatment with early endometrial cancer or atypical hyperplasia were allocated to 3 groups. One of them was treatment with a Mirena, another one was treatment with Mirena and metformin, and another one was a group of women that were put on a weight loss program, and there was quite successful results. So 43% of women with endometrial cancer had complete regression of their endometrium to normal within 6 months, and of the women with endometrial hyperplasia, 82% had complete regression within 6 months. The problem, of course, is once you take away the progesterone treatment, then the problem recurs unless you actually address the lifestyle factors and the obesity that goes with it, because the young woman will continue to be anovulatory. So we take out the Mirena, they want to go and get pregnant, which is fine, but then the problem just recurs. So we need to be looking more at than just the progesterone treatment. We need to be looking at their lifestyles. So the progesterone blocks the action of the estrogen, stops the proliferation of the endometrium. Now we know it's long been recognised in New Zealand that Pacific women have a higher burden of endometrial cancer. And there was a study in 2012 that looked at the high and increasing risk of endometrial cancer, and it found it was largely exclusive to young Pacific women. And it's also increasing significantly in a relatively short period of time. So in 1996, the incidence was 1.9 per 100,000 women, and in 2012 it was 24.2. That was across all ethnicities within New Zealand. And then there was a study at Middlemore where Susan Bigsby looked at women with endometrial cancer over a 15-year period between 2000 and 2014. And they found that Counties women have a higher incidence and worse outcomes than Maori and other women and all women in New Zealand. And there was a marked increase in incidence, especially in women aged less than 50 years old, in Pacific Island women. Excuse me. So in summary from that review, the age standardised incidence of endometrial cancer in Pacific women at counties in 2011-14 was 46.06 per 100,000 compared to a national average of 24.2 per 100,000. So you can see we do have a real significant issue in our population with endometrial cancer. And because we know that endometriums cover a spectrum and it's a slow development, we do know that it is preventable if we intervene at the right stage. So that's why it's very important that these women are investigated and managed appropriately. And traditionally, I think we were all taught that endometrial cancer is a disease of older women or women over 40, and you don't need to be too concerned in young women. In the last 12 months, we've diagnosed endometrial cancer in an 18-year-old. I saw on Wednesday a 28-year-old with a stage 3C endometrial cancer. We have a huge number of young women with atypical endometrial hyperplasia that if we don't act on that at that time, they will get endometrial cancer when they're young. So the traditional teaching in our population does not apply anymore. So what can we do? We need to push the diagnostic intervention point to an earlier stage in the evolution of disease to prevent endometrial cancer and prevent pre-cancer. And the mainstay of that is progesterone treatment, because in premenopausal women, the high estrogen prevents ovulation, so you don't get the luteal production of progesterone. So they are essentially having unopposed estrogen, which we all know from being taught about HRT is not particularly good for endometrial health and causes endometrial cancer, but these women are doing it naturally themselves. So oral, you can treat it orally with high-dose progesterone or a Mirena. Mirena is better because women are notoriously not particularly good at taking their medication. And once they've had a pre-malignant diagnosis, then it's important that they're followed up regularly with sampling of the endometrium. And in fact, they're really, for the rest of their life, until they really have to have some sort of endometrial sampling, because unless you remove the cause of the problem, it's going to recur at some point. And so once these women have had a baby or they feel their family is complete, then hysterectomy is still the gold standard treatment. But if we can get the stage of the changes before they progress to a pre-cancer, then hopefully all of that is preventable. And thirdly, we need to increase the risk of awareness of the risk of endometrial cancer in young women. So if in doubt, refer. We're always happy to see referrals if you're concerned about the bleeding in these women. Early referral, tissue sampling and investigation. I think the guidelines need standardisation and we need to review it with our own local data. I think data from overseas is not necessarily relevant to our own population, as we have quite a unique population here in New Zealand. And a lot of the guidelines from around the country are actually using overseas data and overseas guidelines, which I don't think necessarily is what we should be doing at this point. And we need to do our own audits and research. We need to aggressively hormonally manage menstrual abnormalities in young women to prevent this progression, because as I said, they're not producing their own progesterone. We also need to look at it a little bit holistically and not just give them hormones, but refer to weight loss management and discuss lifestyle factors with it, because that is actually the cause of a lot of this disease. And we need to increase the awareness in the communities that abnormal bleeding is not normal. Certain ethnicities regard heavy bleeding and abnormal cycles as just something that everyone puts up with. Well, I think we have a duty to make sure that they understand that's not the case and there's something that we can do about it. So thank you for listening.